Mood and affect. Emotions, mood and affect are critical elements of the human experience in that they shape and reflect our perceptions of and interactions with the world around us. Emotions, an individual's feeling responses to a wide variety of stimuli. It is reactionary and linked to a specific event or object that can be identified by the person. Mood, an enduring state of mind rather than a discrete reaction, it can shape a person's general expectations about the future. Moods do not produce observable physiological reactions. Affect, an individual's automatic reaction to an event or situation, the immediate, observable expression of mood. Akathisia, state of agitation, distress, and restlessness that is an occasional side effect of antipsychotic and antidepressant drugs. Catatonia, inability to move normally and behavior arising from a disturbed mental state, staying still, fast or strange movements, lack of speech, etc. Anhedonia, inability to feel pleasure. Delusions, a belief or altered reality that is persistently held despite evidence or agreement to the contrary, generally in reference to a mental disorder. I think I got drugged last night, or I'm being spied on by the government. Persecution delusion, harm by others, worry about safety. Reference delusion, think everything is referring to you, song, TV. Grandeur delusion, think you're the best and have like superpowers and shit. Echocolia, meaningless repetition of another person's spoken words. Echopraxia, copying someone's movements. Extrapyramidal side effects, drug-induced movement disorders caused by certain antipsychotics and other drugs. I.E., tardive dyskinesia. Hallucinations, sensory experiences that appear real but are created by your mind. Hear a voice or see something that no one sees. Pseudoparkinsonism, adverse effect of drugs that cause symptoms resembling Parkinsonism such as tremor, mask-like facies, drooling, rigidity, and stiff gait. Psychosis, a severe mental disorder in which thought and emotions are so impaired that contact is lost with external reality. Tardive dyskinesia, side effect of antipsychotic medications. Stiff jerky movements of your face and body that you can't control. I.E., eye blinking, sticking your tongue out, waving your arms without meaning to. Treat with cogentin, benztropine / decrease or switch meds. Word salad, unintelligent, extremely disorganized speech or writing as a manifestation of a mental disorder. Basically putting a bunch of words in a bowl of salad that don't make sense. Ida. Yesterday dogs when I got ice cream didn't do that. Risk factors. Economic/social factors such as rapid changes, stressful work conditions, and isolation. Unhealthy lifestyle choices such as sedentary lifestyle or substance abuse. Exposure to violence, such as being a victim of child abuse. Personality factors. Spiritual factors. Cultural factors. Changes or impairments in the structure and function of the neurosystem, cerebral abnormalities. Psychosocial developmental level and issues. Genetics. Neurochemical transmitters. Assessment. Determine mental ability of patient and complete health history. Past medical treatment for mental health. Past counseling services. Family HX of mental disorders. Ability to carry out ADLs. Substance abuse. Current stressors in life. Suicidal ideations / attempts *. If patient can't sit through full assessment, have family member present. Examination, inconsistent orientation, concentration, posture, level of anxiety, level of appropriateness, label behaviors, inappropriate dressing, cold weather clothes worn in the summer, abnormal speech, observe thought process, identify suicidal tendencies *. Abnormal involuntary movement scale, AIMS. Definition. The Abnormal Involuntary Movement Scale, AIMS, is a rating scale that was designed in the 1970s to measure involuntary movements known as tardive dyskinesia, TD. TD is a disorder that sometimes develops as a side effect of long-term treatment with neuroleptic, antipsychotic medications. Exemplar, schizophrenia, complex brain disorder that affects thinking, language, emotion, social behaviors, and the ability to perceive reality correctly. Syndrome or disease process with many different varieties and symptoms as noted in the DSM-5 criteria. Exact cause is unknown, can be a combo of genetic, biological influencer, cultural, and psychological factors. Many live successfully in the community. Diagnosed in late adolescence or early adulthood *. Peak onset is 15 to 25 men, 25 to 35 women. Schizoaffective disorder, diagnosed when the client is severely ill and has a mixture or psychotic and mood symptoms. Clinical manifestations. Soft symptoms, negative. Hard symptoms, positive. Flat affect. Avolition, lack of motivation, putting off tasks. Social withdrawal or discomfort. Anhedonia, lack of pleasure. Apathy, lack of mood or enthusiasm. Blunted affect, difficulty expressing emotions *. Catatonia. Inattention. Delusions. Hallucinations. Psychosis, depersonalization/derealization. Grossly disorganized thinking, speech, and behavior. Flight of ideas. Echopraxia/echolalia. Clang association, rhyming words. Word salad. Ambivalence, mixed feelings. Perseveration. Schizophrenia types. 1. Paranoid, strong irrational suspicion with dominant symptoms of delusions and hallucinations. If a client sees the nurse is talking with a psychiatrist, they may believe it's about them. 2. Disorganized, most socially impaired form. Dominant symptoms of disorganized speech and behavior as well as inappropriate affect. Bizarre mannerisms, poor hygiene, constant muttering to oneself, often found in homeless population *. 3. Catatonic, abnormal levels of motor behavior, either extreme motor agitation or retardation. Withdrawn, mute, refuse to participate in activities, versus hyperactive behavior, talk, shout continually. Schizophrenia pharmacology. First-gen/conventional antipsychotics, used to treat positive symptoms of schizophrenia *. Chlorpromazine, thorazine. Thiordazine, Mellaril. Flufenazine, Prolixin. Haloperidol, Haldol, hook them up to an EKG. * more harsh med, first gens. Increases likelihood of NMS/EPS. Second generation/atypical antipsychotics, you're atypical. Treat positive and negative symptoms. Helps decrease bizarre behaviors and depressive symptoms. Olanzapine, Zyprexa. Risperidone, Risperdal. Quetiapine, Seroquel. Aripiprazole, Abilify. With second-generation antipsychotics, atypical, you have increased risk for metabolic syndrome and less likely for NMS/EPS because they are atypical. Be aware of what you're eating, increased risk for cardiovascular complications, neurovascular complications, renal complications, and your weight. * with all antipsychotics you start at lowest dose and work your way up until you have reached the therapeutic blood level to decrease the risk of any of these side effects. Education for all antipsychotics. Suicide for both and safety risk. They can take 4-6W to be effective. Don't stop abruptly, both. Report temp, NMS. Monitor for metabolic syndrome, more second-gen weight gain, can't control glucose, high BP, high lipids, risk for cardiac issues, stroke, heart attack, diabetes. Agranulocytosis, monitor S/S of infection. WBC. Extrapyramidal symptoms, tardive dyskinesia, akathisia, dystonia, life-threatening in the neck. Treat EPS with cogentin and benztropine, benzo, and or lower the dose or change meds. Anticholinergic effects. Dry mouth. Constipation/urinary retention. Dry mouth. Flushed skin but not sweating. Very dry. Blurred vision. Photophobia. We can. Suggest SF hard candy or gum. Sips of fluid. Give foods high in fiber, up fluid, stool softener, raw fruits and veggies, grains. Wear sunglasses outside. Schizophrenia nursing considerations. Assess suicide and safety risks. Safe, secure, MIWI environment, therapeutic, and structured. Establish a trusting relationship. Avoid direct questions. Client may feel threatened. Maintain therapeutic, objective, clear, concise communication. Calm tone, address client by name, observe for early S/S of escalating behavior. Tolerate silences. Client may be too anxious to speak. Reduce stimulation, provide solitary activities, stuff you can do alone, reading, until they are able to participate in group activities. Provide simple activities or one that promotes self-esteem. Finger painting, clay, art therapy, avoid competitive activities ***. Exemplar, bipolar disorder go from one stage to the next. Very happy, sad, hopeless, down. Bipolar disorder I, mood disorder characterized by at least 1 week-long manic episode. Manic episode may alternate with depression, some sort of remission. Bipolar disorder 2, low-level mania alterations with profound depression. Risk factors. Neurochemical risk factors, serotonin plus norepinephrine. Hormonal fluctuations. Genetics, 10x more likely. Psychological stressors. More common in highly educated individuals. First manic episode usually occurs between teenage 30 years. Young men in early onset of illness equals highest risk for suicide. Bipolar clinical manifestations. Manic/mania, happy, energized. Depressive, down, depressed. Begin suddenly. Escalation of symptoms over course a few days, lasting weeks. Euphoria, heightened, grandiose mood. Attention-seeking behavior. Agitation, increased emotion. Exaggerated self-esteem, goes W, grandiose mood. Sleeplessness, prob not taking care of themselves. Pressured speech, increased talking fast with urgency, go off on tangents. Flight of ideas. High-risk activities, poor judgment, impulsivity. Increased energy. Possible presence of hallucinations or delusions. Gradual slide into depressive state. May last weeks to months. Flat, blunted effect. Tearfulness/crying. Anergia, lack of energy. Anhedonia, lack of pleasure. Difficulty concentrating, focusing. Self-destructive behavior. Decreased appetite. Disturbed sleep. Psychomotor agitation/retardation. Bipolar disorder pharmacology. Lithium, therapeutic level 0.6 to 1.2 milliequivalent/L, becomes toxic 1.2 milliequivalent. Takes a few weeks to kick in, might be put on anticonvulsant/antipsychotic in the meantime. Toxicity, N/V, abdominal pain, lethargy/confusion, muscles weakness/tremors, slurred speech, increased U/O, convulsions, ataxia, drunk looking. Diet considerations, continue to eat salt. Salt risk for toxicity. Daily weights, strict INO. Weekly therapeutic level check, labs frequently. Take med same time every day. No alcohol. Anticonvulsants aka mood stabilizers can be given in conjunction with lithium to decrease the amount of lithium needed. Carbamazepine, Tegretol therapeutic level for -12 mcg/ml. Bone marrow suppression. Valproic acid, Depakote therapeutic level 50-120 mcg/ml for mania. Side effects, photosensitivity, hepatotoxicity, bone marrow suppression. Monitor for liver enzymes *, Point may complain of RUQ pain, nausea, anorexia, fatigue, jaundice. Monitor for bone marrow suppression, CBC, low platelets. Antipsychotics. SSRI antidepressant. Monitor for serotonin syndrome. Sertraline, fluoxetine. S/E of SSRIs, weight gain, orthostatic hypotension, decreased libido, increased risk for GI bleed, suicidal ideation asterisk. Avoid alcohol and OTC drugs. Tell provider, do not stop abruptly. SSRI antidepressant. Serotonin syndrome. 1. Withhold med. 2. Stabilize vitals. 3. Cardiac monitoring. 4. IVF. 5. Supportive care. 602 admin. 7. Benzos for sedation. Electroconvulsive therapy for bipolar, ECT. Try meds first asterisk. A treatment procedure that passes an electrical current through the brain to induce a seizure. Usually given 2 to 3 weekly, for 3 to 4 weeks until a course of 6 to 12 treatments is completed. ECT takes approximately 2 to 3 months to reach desired effect. Effective in treating depression, increases serotonin and norepinephrine. Associated with improved mood, functional status, anxiety, and quality of life. Especially used for patients with severe depression who are resistant to other treatments, who are severely suicidal, and for those with severe psychomotor retardation. Connect to EEG to monitor brain, and EKG for heart monitoring. If patient is on Ativan, hold or decrease it because it's an anti-seizure med. Prior to ECT, medical history, physical exam, mental health assessment. Blood work, ECG. Pre-procedure. Anesthesia. Informed consent could also be court-ordered. NPO at MN. Void prior to start. Hold benzo or anti-seizure/anticonvulsant. IV access. Remove dentures, contacts, jewelry. During procedure. Ambu bag/airway. Bite block, SZ. Vital signs. Post-procedure. Monitor gag reflex/mental status after sedation/paralytics. Mild confusion/temporary short-term memory loss common. Headache. May feel tired or report muscle aches. Recover in a lateral recumbent position to prevent aspiration. Patient should not drive for the remainder of the day and should have someone with them. Bipolar disorder, nursing considerations. Provide for patient's safety and those around. Assess suicidal tendencies. Decrease stimulation, milieu environment, seclusion. Limit setting, if applicable, don't allow manipulation. Monitor for escalating behavior. Calm, matter-of-fact communication. Seclusion may be someone trying to harm themselves or others. Restraints if they're acting towards harming others. Consistency of staff members * follow that schedule with them too. Promote rest and sleep. Diet of finger foods, high calorie, more so for mania when they're on the run, and protein encourage nutrition and eating. Safety especially during manic state. Can do CBT and DBT.